Good evening, friends. Today we are going to discuss another very important topic, that is pregnancy with diabetes. In our OPD, we are treating many patients, and many female with pregnancy came to us with impaired blood sugars or higher raised blood sugars. So in this lecture, we will see how we are going to treat them, how we are going to manage and diagnose them. We will see one by one. So first is what are the changes in pregnancy we are seeing that makes them different from non-pregnant state. So what are the difference in pregnancy and non-pregnancy? In pregnant female, the fasting blood sugars are low, and they are post-meal blood sugars are high. Um, and why it is so? It is due to there is a decreased sensitivity and increased secretion. Means there is decreased sensitivity means increased resistance, increased insulin resistance, and to overcome this, body has to increase the secretion. Once body increases secretion, to maintain the blood sugar to optimum level. And how once the body is increasing the secretion means the function is increasing, so there is beta cell hypertrophy with hyperplasia, means there is increased number of beta cells as well as increased size of beta cell. So there is increased size and number both. So these are the three common changes we see in a pregnant female that makes them different from the non-pregnant state. Now we have to find the cause of diabetes. The when you are practicing in your OPD or in a private sector and a patient came to you, you need to satisfy the patient. You have to counsel the patient. You have to explain the patient. Once the patient asks you, sir, why I am diabetic? I don't have any history. Means without history of diabetes, how can I get diabetes? So you have to tell the patient these three are the most common reasons, and most easy and convenient is idiopathic, that we don't know the reason. The reason can be genetic. This is multifactorial basically. It can be genetic, can be environmental, can be dietary, can be some other factor. And the second most common is autoimmune destruction of beta cells. As we know that pregnancy is a state of insulin resistance, and we have an extra organ in pregnancy, that is placenta. So that can make auto antibodies, and that can lead to destruction of beta cells, and that can destroy beta cells and leads to diabetes. As we see, there is impaired beta cell function as very well known factor. So when the function is impaired, the blood sugars keeps fluctuating. These are the three main causes. So now we came to the diagnosis. We have to diagnose the patient that what kind of diabetes he is having. He is pre-gestational diabetes, or he is having gestational diabetes, or he is impaired blood sugars, यानी कि impaired blood sugars in gestational. So as we all know that HbA1c, the more than 6.5 is considered as type 2 diabetes. It is the one of the diagnostic criteria of diabetes, but in the pregnancy it is not that much reliable because it yields high false positive results. So we will not rely on HbA1c alone, but yes, we will order the HbA1c to know the status of the glucose control. If patient is pre-gestational, means patient is diabetic before conceiving. So if patient is diabetic and having some oral medication, oral anti-diabetic agents, so we will order the HbA1c, that how well controlled her blood sugars are. If the blood sugars are poorly controlled, we will make change accordingly. And for the diagnosis, we will do a 75-gram oral glucose tolerance test. So oral glucose tolerance test, we have three kind of oral glucose tolerance. One is 75 gram, one is 50 gram, one is 100 gram. Most convenient and most reliable is 75 gram, and it is also feasible to the patient. It is cheap also, because we need only one value to diagnose the patient. So we are using, in our OPD, we are using only 75 gram of oral glucose tolerance test. Many gynecologists, they might use 50 grams, where they do the serial monitoring after 1 hour, 2 hour or 3 hour and fasting. So but as a medicine expert, we are doing 75 grams, as we require only a one value to diagnose. So we give the 75 gram of anhydrous glucose, and we take the sample after 2 hours, and we find that the blood sugars are more than 200. If blood sugars are more than 200, the patient is having diabetes. It's not gestational diabetes, it is diabetes, means before conceiving, patient is having diabetes, but she might not know the fact, or she might having diabetes on taking medication. So blood sugars are more than 200 is in diabetes only. And if the blood sugars are between the 140 to 199, it is gestational diabetes. This is the important factor where we are discussing now. There, if the blood sugars are between the 140 to 190, this is gestational diabetes. Means pregnancy, means the patient is diagnosed first time in pregnancy. If the blood sugars after the 2 hour is between 120 to 139, it is gestational glucose intolerance. Means it is kind of pre-diabetic state. Means if we are not giving giving her a medication nutritional therapy, or we are not controlling the factor, it will lead to gestational diabetes. So this is a glucose intolerance, means pre-diabetic state. And if the blood sugars are less than 120, that is a normal range. Patient is absolutely normal. So we have seen the diabetes, gestational diabetes, and glucose intolerance. So the most important part is, now we come to the most important part, that is the management. So what are the treatment options with we have? So first we have to set the target values, fasting blood sugar. So our target fasting blood sugar is 70 to 90 milligram per deciliter, and post meal blood sugar between 100 and 120 milligram. So the range is quite narrower than the non-pregnant state, because as we know, the glucose which is high in diabetes is teratogenic to the fetus. So this is teratogenic to the fetus. So we have to keep the blood sugars in a maintain the blood sugars in a narrow range. So now we came to the pre-gestational diabetes. The patient is already diabetes and conceives later. So and taking some oral medication, oral hypoglycemic agents. So we will shift her to insulin. We will ask the patient to stop all OHs and then shift her to insulin. If patient is already diabetic, diabetes means her beta cells function is already compromised. If function is compromised, so the requirement of insulin is higher. So it is usually higher than gestational diabetes. And regimen, we have two regimen with us. The first is basal bolus, and second is split mix regimen. In basal bolus regimen, we need to give a pre-meal short-acting insulin and a intermediate or long-acting insulin at the bedtime. Pre-meal short-acting insulin given 3 times a day, that is before breakfast, before lunch, and before dinner. So we are giving 4 pricks per day to the patient, and this short acting insulin will take care of immediate spurt in blood sugars, and the intermediate acting insulin will take care of all day long for the blood sugars. And split mix regime, we have a biphasic insulin which will given before breakfast or before lunch or before dinner. Means we are giving 2 pricks per day. So as we compare, here are the 4 pricks, this is the 2 pricks. So the split mix regime is more compliant to the patient. Patients are more compliant for this. And but the blood sugars are very well. But when we compare blood sugar control, the basal bolus regime is better to control the blood sugar. But a split mix is also a good option, because as we know, the patient is most of the time patient is reluctant to the insulin, so it is very difficult to counsel the patient to take the insulin. So 2 pricks is okay. Now for the insulin, we have two options. One is short acting and another is pre-mix insulin. In short acting insulin, we have Novorapid, Actrapid, and Humalog. Novorapid include Aspart, Actrapid has regular insulin, and Humalog have Lispro. So these are the short acting insulin. Novorapid and Human Actrapid, these are the brand name and available in the market in pen and syringe also. So pen is more convenient to the patient, so most of the time pen is advised if patient can afford. Premix insulin, we have 3 options in the market: Novomix, Humalog mix, and Human Mixtard. Many more options are there, but these 3 are most common. In this, we have a short acting insulin and a intermediate acting. Short acting in Novomix is Aspart, Humalog is Lispro, and in Mixtard it is regular, that is short acting insulin. And the concentration available in the market 36, 30-70 or 50-50. 30-70 means there is 30% intermediate acting insulin and 70% is short acting insulin. In 50-50, we have 50% short acting and 50% is intermediate or long acting insulin. So these are the insulin available in the market. You can advise to the patient according to the regimen. Now the gestational diabetes. Once patient is diagnosed as gestational, first we need to diagnose, by the definition, means if the patient is diagnosed first time in pregnancy at 20 weeks or later, and the blood sugars are more than 140, we will live, and less than 199. This is the criteria for gestational diabetes. And first therapy is always medical nutritional therapy. So we will advise diet modification or diabetic diet to the patient. If it fails, we will switch to patient to insulin. As we know that gestational diabetes require lesser units of insulin, so the unit, most of the time it is restricted to 20 units per day. And when once we give a medical nutritional therapy, when we have to switch to the insulin, when we advise the medical nutritional MNT, and we will monitor blood sugar, and if values are more than 4 values out of 7 in a week is above the cutoff level, this is the indication to start the insulin. Means our MNT, medical nutritional therapy, is not working. So sugars are higher, and cutoff is fasting is 93 and post meal 140. If more than 4 values out of 7 is higher than this range, we will start the insulin. We will continue with nutrition therapy, but we will add the insulin. Premix is preferred, as we know. Two pricks are required, so patient is more compliant. So premix insulin is preferred. And now how we are going to start the insulin? So we will start with 4 units before breakfast. This is the single time insulin. We will give 4 units, and then every fourth day we will increase the insulin by 2 units if cutoff level crossed. Means if you start the insulin with 4 units before breakfast and blood sugars are still more than 140, post meal blood sugars are still more than 140, you will add on the 2 units on fourth day, and you keeps on adding until you get the blood sugar value less than 93. Once you get it, we will get the total dose of insulin, and then we will split this dose in two-third and one-third. Two-third given before breakfast or lunch, and one-third given before dinner. This is for the premix insulin. So total dose can be divided. For the premix insulin, when we are giving 2 pricks, you can divide the total dose in this form. If you found that blood sugar, means the patient is of pre-gestational diabetes, if blood sugars are more than 200, you can start with 80 units. Means you will give 8 units before breakfast, and then you will titrate the dose. Every fourth day you will increase the dose by 2 units, and then when you get the value less than 93, you will split the dose into two-third and one-third, and then you will continue with monitoring and titrate accordingly. So this is how we will start the insulin in pregnancy. You need not to calculate per kg insulin dose per kg, because the response is very unpredictable. So just start with low dose and then go slowly. So once you are given insulin to the pregnancy, and you see in between the treatment the insulin requirement suddenly drops. Means let's say, for example, if patients requires 80 units per day insulin, and after a few days she starts taking 10 units per day, and still the blood sugars are less than 93, means, so this is the red flag sign and the immediate indication to check the fetal well-being. If there are any fetal damage or any placental insufficiency, the requirement drops significantly. So what about the oral glycemic drugs? So we have collected many data from the clinical trials, and we have concluded that, and all the clinical trials, they say that the role of OHO on oral anti-diabetic agents are controversial, and none of the clinical trials they favor oral drugs over the insulin. Means this is the only drug in pregnancy which can be safely given without any teratogenic effect. But when the patient came to you and you ask the patient to take the insulin or take the injection, you always find the patient are reluctant to taking the insulin. Means they may find someone else. If you are insisting for insulin, they will find someone else to give some other therapy, some Ayurvedic therapy, some oral therapy, some diet therapy, but they will reluctant to insulin. Although this is going to affect the fetus, but initially they are very reluctant. So for these patients, you can start metformin. Metformin is the only drug who in few clinical trials they say this can be given safely with monitoring, and is the only drug you can start, and the available brand name is glycomate, gluconome or glyciphase, and the strength available in the market is 500, 850 and 1 gram. So we will start with 500 milligram BD, and we will continue with monitoring. We will monitor the blood sugars, and with the ultrasound we will monitor the fetal well-being also, right? And later we can switch the patient to insulin if required. If patient is already on metformin, means from the pre-gestational state, patient is taking metformin for some obstetric indication, means like for example, patient is having PCOD and she is on metformin, and patient after that patient conceives, so you can continue with metformin. There no need to shift over insulin. If blood sugars comes in abnormal or above the cutoff range, then you can change, you can think of shifting the patient to the insulin. But till then you can continue with metformin and you can continue with the monitoring. None of the sulfolin ureas or none of the category of oral agents found safe in pregnancy. So best is insulin, and we have seen that how we have to give, how we have to start the insulin, how we going to titrate the dose of insulin, all things we have seen. So friends, thank you so much. This is all about, you need to know about the diabetes in pregnancy, a very sophisticated state of our life where the things are sometimes difficult to manage. So thank you so much.